Coming to the last case of vitamins, a 42-year-old female presented with a sensation of cold numbness in the tips of the toes, fingertips, occasionally with lancinating pain. She also complained of constriction in the abdomen and chest, limb weakness, and ataxia. The symptoms were aggravating since past 1 year. She gave a history of frequent episodes of diarrhea and weight loss. She was a strict vegetarian and did not even consume the milk and the milk products. On examination, she was anemic, tongue was beefy red, fissured, and neurological examination revealed numbness in all extremities with decreased vibration senses. So, with all the above presenting history and examination findings, we can diagnose her to be of a case of megaloblastic anemia. Now, this megaloblastic anemia is mainly due to vitamin B12 deficiency. Now, what this vitamin B12 is? Vitamin B12 is a water-soluble hematopoietic B complex vitamin, which is also known as the anti-pernicious anemia factor, also called the extrinsic factor of Castle, and also called the cobalamin, as cobalt is linked to Corin ring. It is unique vitamin since it is synthesized only from microorganisms and not by animals and the plants. Now, and also the speciality of this vitamin is that it is the only water soluble vitamin which is stored in the body. Now, looking at the sources of this vitamin B12 is mainly from the animal sources. It is absent in the plant foods. Richest sources are liver, kidney, eggs, curds, milk, fish, pork, etc. So, vitamin B12, it is said that curd is a better source of vitamin B12 than milk because the lactobacillus in the curd synthesizes vitamin B12. Vitamin B12, as I mentioned, is synthesized only by the anaerobic microorganisms. Animals obtain B12 either by eating foods derived from other animals or from the intestinal bacterial floral synthesis. The RDA of vitamin B12, adults recommended dose is 2 microgram per day. Children, it is around 0.7 to 1.4 microgram per day. During pregnancy and lactation, it is increased, that is to 2.2 to 2.6 micrograms per day. Coming to the biochemical basis of the presentation of a case of megaloblastic anemia. Now, correlating the biochemical functions and the presenting signs in a case of megaloblastic anemia, cobalamin is involved in the maturation of RBCs in the bone marrow. So the coenzyme forms of vitamin B12, as we know, are methylcobalamin and deoxyadenosyl cobalamin. It's involved in the metabolism of every cell of the human body, particularly important in the maturation of RBC in the bone marrow. This vitamin B12 is necessary for the hematopoiesis, normal functioning of the nervous system, myelin sheath formation, DNA and the RNA production, and also has a role in carbohydrate, fat and the protein metabolism. It plays an important role in the synthesis of methionine, choline and also in regeneration of the folic acid. In case of this megaloblastic anemia, that is caused by vitamin B12 deficiency, this also causes simultaneous folate deficiency due to the folate trap. Hence, folate deficiency manifestations are also seen in a case of megaloblastic anemia. Megaloblasts and immature RBCs are seen in a peripheral smear. Megaloblastic anemia in vitamin B12 deficiency is mainly due to impaired DNA synthesis, preventing cell division and formation of the nucleus of new erythrocytes, which in turn results in accumulation of the megaloblasts in the bone marrow and release of immature erythrocytes into the circulation. In case of vitamin B12 deficiency, subacute combined neuronal degeneration is a unique presentation and is not associated with folate deficiency. This is named as combined degeneration as both sensory and motor tracts are affected in vitamin B12 deficiency. Pathological findings of subacute combined degeneration consists of patchy losses of myelin in the dorsal and the lateral columns. Patients present with weakness of legs, arms, trunk, tingling and numbness that progressively worsens. Vision changes and change of mental state may also be present. So coming to the next part, that is assessment. How do you assess a case of the megaloblastic anemia? So here we have to look for the various parameters, that is serum vitamin B12 levels, as this is due to vitamin B12 deficiency. Normal serum vitamin B12 level is 162,000 picogram per ml. Quantitative estimation is done by the radioimmunoassay or the chemiluminescence method. Next is a Schilling test. 1 microgram of cobalt 60 radio labeled vitamin B12 is given orally. If there is gastric atrophy, vitamin B12 is not absorbed and hence radioactivity is not seen in the liver region. So this can give us the vitamin B12 deficiency. What happens in this? All the radioactive labeled vitamin B12 is excreted out in the feces due to the gastric atrophy where vitamin B12 cannot be absorbed. Then we have the Figlu excretion test or the histidine load test is positive due to associated folate deficiency. Then the peripheral blood smear and the bone morphology will show megaloblastic anemia. Oval macrocytes, teardrop cell, hyperpigmented neutrophil, anisocytosis and poikilocytosis, as well as basophilic stippling of the erythrocytes and Howell-Jolly bodies are also seen in the peripheral smear. We also can look for the methyl malonic acid, which is excreted out in the urine in case of megaloblastic anemia. Then homocystinuria also can be seen due to vitamin B12 deficiency. Coming to the treatment part, all the macrocytic anemias and the megaloblastic anemia should be treated with both vitamin B12 and the folic acid supplements. This is because if megaloblastic anemia is treated with only the vitamin B12, the anemia might get corrected, but associated nervous lesions get aggravated due to deficiency of either, due to folate trap and vitamin B12 deficiency and the folic acid deficiency. Both should be supplemented to correct the anemia and the associated nervous lesions. So therapeutic dose of B12 is 1000 IM subcutaneously given daily for 5 days followed by for 5 weeks. So this concludes the megaloblastic anemia, which is mainly due to vitamin B12 deficiency. The vitamin related cases were mainly the 2 of fat soluble vitamin cases, that is vitamin A deficiency and the vitamin D deficiency, rickets and the osteomalacia. Then cases related to water soluble vitamins were mainly the beriberi. Then we have the pellagra and the megaloblastic anemia and the scurvy. Thank you and have a nice day.